Caring for women who've experienced female genital cutting. The objectives of this video are to review terminology in the WHO classification, provide an approach to vulvar examination, review health consequences, and considerations for the procedure of defibulation. Data has shown that healthcare practitioners have challenges in providing quality care to women that have experienced female genital cutting. They are often underprepared to assess and manage complications, lack technical skills to provide procedures such as defibulation, and face communication challenges. Additionally, women that have experienced female genital cutting have expressed concerns with the quality of care they've received. Female genital cutting is a ritual removal or injury to any part of the female genitals for non-medical reasons. The words we use matter. There is no international consensus on terminology. Female circumcision is problematic because it equates the practice with male circumcision. Female genital mutilation is an advocacy term, however, can be considered judgmental and stigmatizing. As medical practitioners, we should use the term female genital cutting as it is medically correct, neutral, and culturally sensitive. FGC is a complex global public health issue. It's considered to be a harmful practice, a violation of human rights and the rights of a child. It is also a form of gender-based violence. The WHO estimates that over 200 million women and girls have experienced FGC, and 3 million girls are at risk each year. The practice is known to occur in over 40 countries, with the highest prevalence in Somalia, Sudan, Egypt, Eritrea, Djibouti, and Guinea. It is often misunderstood, even by healthcare practitioners, that the entirety of the clitoris is removed with female genital cutting. This is a misconception. The clitoris is a multiplanar structure that surrounds the urethrovaginal complex anterolaterally. It is centrally attached to the urethra and vagina. The main components include the clitoral glands, body or corpora, the crura, and the vestibular bulbs. The external components are the clitoral hood, which connects to the labia minora via the frenulum, also known as the prepuce. It drapes over the clitoral glands. It's these two components plus the clitoral body that are often cut. The World Health Organization has classified FGC into 4 types with subcategories. Briefly summarized, they are: Type 1A, partial or total removal of the clitoral hood. Type 1B, the clitoral hood plus the clitoral glands. Of note, when the WHO refers to clitoral glands excision, it can also include partial excision of the clitoral body. Type 2A, partial or total removal of the labia minora only. Type 2B includes the labia minora, clitoral glands, and sometimes the clitoral hood, whereas Type 3C includes the clitoral glands, labia minora, and labia majora, as well as sometimes the clitoral hood. Type 3 is infibulation, where the labia minora or labia majora are cut and appositioned, narrowing the vaginal opening. Type 4 is all other harmful procedures such as pricking, incising, scraping, or cauterization. They may have a normal appearing vulvar examination, however, have a significant history of a harmful genital procedure. A simplified approach to the classification would be to observe if the clitoral glands has been cut. This could be any type. If the clitoral hood has only been cut, it's a type 1. If the labia minora or majora have been cut, it is a type 2. And if there's infibulation, this is type 3. FGC can alter the health trajectory of a woman's lifetime. Consequences can be experienced in multiple spheres of health and wellness. Immediate consequences can include severe pain, bleeding, hemorrhage, shock, infection, broken limbs, and even death. Sexual function can be impacted in terms of lack of sensation, dyspareunia, diminished arousal or desire, and anorgasmia. The psychological impacts can be significant and influence one's identity, belonging, and body image. There's also increased rates of anxiety, depression, and post-traumatic stress disorder. Obstetrical consequences can include prolonged labor, increased perinatal tearing, increased need for interventions such as episiotomy, instrumental delivery, and cesarean section. Long-term complications include chronic pain, dysmenorrhea, genital tract infections, infertility, and difficulty with gynecological procedures and screening. They can have keloid scarring, recurrent vulvar abscess, and epidermoid cyst formation. Medical history taking should be done in a respectful, culturally sensitive, and non-judgmental manner. Use a person-centered approach that focuses on her lived experience of cutting and how it has impacted her physically, mentally, and socially. It's important for the practitioner to understand that the experience of cutting can be highly diverse. The range of impact is on a wide spectrum and can change throughout one's lifetime. Example questions could include, what do you remember about being cut and how has this impacted you? Documentation is important to alert other healthcare providers and avoid unnecessary examinations. Use a diagram, not only for your medical records, but as a teaching tool for your patient to explain their vulvar anatomy. Use the WHO classification system. If it's unclear, describe the anatomical structures that have been removed or injured. In the setting of type 3 with infibulation, the process of defibulation can be used to open the midline vulvar scar. Indications include personal choice to improve urinary menstrual outflow, to decrease genital urinary tract infections and cyst formation, to permit vaginal penetration and decrease dyspareunia, and permit vaginal delivery and decrease obstetrical intervention. Defibulation is a simple procedure, however, the complexity lies in preoperative counseling and expectation setting. Considerations include it's not only an anatomical and physiological change, it can alter body image and represent a cultural shift, especially around marriage eligibility. Discuss alterations in vaginal discharge, urine stream, and menstruation flow. Review clitoral anatomy and the possibility the clitoral glands may be found intact under the scar. Agree on the amount of opening. For example, some women prefer a partial defibulation. Develop an anesthetic plan. Defibulation can be done under local, spinal, or general anesthetic. Operative and postoperative pain can trigger post-traumatic stress disorder symptoms, and therefore discussion of this possibility is important in ensuring the availability of psychological support. Steps to the procedure can include marking a line of the planned incision to avoid asymmetry, assessing for underlying adhesions, which can be done by placing a finger beneath the scar. Gently place a Kelly clamp beneath the scar to retract the tissue forward to help protect the urethral meatus and clitoral glands. Move slowly from inferior to superior, observing for the anatomical landmarks. Here you can appreciate the newly exposed glands as well as the defibulated labia. To reapproximate the neolabia, use interrupted foroabsorbable monofilament suture. For further reference, see these additional resources.